stay tuned, because if anything, it's not like in second line is any better. It's as complex, and if anything, it's interesting, and that's great news that now we talk about second line therapy, and there's been a lot of advance in regard to second line therapy, and probably almost all of them already have been FDA approved. And let me start again with Catherine, and I get the patient on, let's go back a little bit, because we're going to play it in two scenarios, and all of us will be involved in this. A patient who got lenvatinib as a first-line therapy. What are you getting from second line?
Well, we don't really have any data at this point of what to do in second line after lenvatinib. You know, all of the second line studies were approved after sorafenib because that was standard of care at the time.
Fair.
I think that I would choose my second line depending on how the patient tolerated the lenvatinib and did they have any response and how good of a response. And you can make an argument for the TKIs, multiple other TKIs like cabozantinib, like regorafenib was for after sorafenib tolerability, so that would depend. You could also make an argument for IO. You could also, go and say, well, what about using atezo-bev as second line now in this patient? So I think we don't have a lot of data to guide us, unfortunately, and it's going to be a little bit of the Wild West until some of the data comes out.
I think it's a good introduction, and you probably got a good taste from what Dr. Fernette said in regard to what will be the second line per se, even though there could be some notions that won't take us one way or the other. And I'll carry on with the same question, and I'll ask Dr. Al-Kuwairi, lenvatinib first line, what will be your second line?
So I think extrapolating that, lenvatinib and sorafenib are both multi-targeted tyrosine kinase inhibitors. So we extrapolate a lot in medicine. So even though the studies were post-sorafenib, we extrapolate and use those agents post-lenvatinib. So as Catherine mentioned, we could use cabozantinib, regorafenib, that study was particularly for patients who tolerated sorafenib, so it may be used less post-lenvatinib. We have ramucirumab for patients with an AFP above 400. Now, with the IO agents, I'll spend a minute on that. Because
I want you to, because remember, that patient actually, the exact same patient I told you, he looked at me and said, like, wait a minute, I heard about something called molecular, genetics, etc., but I also heard about something called immunotherapy.
Yeah.
Yeah.
So we have, in that space, meaning the second line space, we have at least two sets of data, phase 1/2 studies with nivolumab and pembrolizumab that resulted in the accelerated approval of those agents in that space. Now, that accelerated approval was based on a response rate ranging between 15 and 20% for both studies, plus another third agent called pembrolizumab showing consistent data. But in addition to the response rate that was at that time novel and promising, it was the durability of the responses. We're talking the responses being durable above, usually beyond 1 year. Actually, in CheckMate 040, which has the longest follow-up, median durability of response of 17 to 19 months. And we showed, and others showed, that patients who responded did very well as far as survival as well. So this promise led to these agents being used post the sorafenib, post lenvatinib in second line. Now, the challenge came when Keynote 240, which is a phase 3 trial, was conducted in the second line space post sorafenib and randomized patients to pembrolizumab versus placebo. Now, when we first look at this trial, we see a median OS of almost 14 months with pembrolizumab, a median OS of 10, 11 months with placebo, and a p-value of 0.02 something. So it looks on the surface positive, right, and with a clinical benefit. However, because of that study having co-primary endpoints and having multiple interim looks at the data, that p-value needed to be less than 0.017. So statistically, that study was not positive. But we do believe that there's a clinical benefit with a clean separation of the curve and a difference in the median OS in that study. So it poses a bit of a challenge where the single agent PD-1 agents will fit. Now, of course, if we're gonna use PD-1 combinations or PD-L1 combinations in first line, then using single agent PD-1 or PD-L1 in second line would not make sense. But for those patients who got TKIs, it remains a reasonable option.
I have to admit, you're confusing me even further, because now, and Ahmed, please help me here. So I agree with both thoughts, and if anything, I'm hearing the same thing, is that really we don't know what to do. And on top of that, now I'm hearing about a statistically positive study, but clinically not positive.
The other way around.
Or the other way around. But I thought it's a positive study. Do you depend on the use of pembrolizumab, for example, based on the phase 2 data, which actually led to the conditional approval, or do you make an argument based on the phase 3 trial that was rather negative, and this is really what we're going to call it, a negative study? And how do you put all of this together?
Yeah, so it's a question we face every day in clinic, and the simple way of discussing this with patients is, as everybody said, how did they do with the front line? If they got TKI, did they have horrible side effects with the TKIs and hand-foot syndrome and so on, and they want to take a break, in which case we can try some immunotherapy and see if they can handle it, and they would be one of those patients who are gonna. So we all have done that, but in the meantime, you also see those patients who did very well with TKIs, a year and a half, tolerating it well, especially if it is sorafenib, as Dr. Fernette said. Then there is a case to make here for regorafenib, for example. So it really comes back to our initial thought about personalizing therapy approaches for those patients, which one would be carry more risk than the other. Until we get solid data from clinical trials about sequencing, we're not going to get to know. But as we all know, we're never going to see those studies because the field is moving so fast. Immunotherapy now moved up to front line. So now the challenge is going to be, as Dr. El-Khoury was saying, after being exposed to anti-VEGF and anti-PD-1, what to do next.